So I thought I'd call this General Practitioner's Exposure to Personalized Stratified Medicine and Translation to Future Clinical Practice. And it is basically genetics and genomics, but there's other things in there as well. And to anchor the talk, I needed a definition I was comfortable with. I don't know if Munir and the others fits in with your definition, but this came out from NCI and embarrassingly Wikipedia and a bit of me. So it's a form of healthcare that separates patients into different groups with medical decisions, practices, interventions, and/or treatment being tailored to the individual based on their predicted response or risk of disease. And what I'd say is that actually, I've been looking back as well as forward, that actually general practice has been doing this for decades. And we're actually, what we miss sometimes, and Imran brought up in the first talk, was that we need more education. What we actually need is to understand transferable skills. Is what have we done in the past that we can use in the future? And so one of the areas is, how many clinicians work in primary care here? How many of you have seen genetics mentioned in NICE guidelines? Okay, all right. Well, I'll bring that up in a minute. What I was talking about in terms of where we're coming from, I think every GP here has done personalized medicine. I found this, it's about 40 years old, but it's really interesting. It's actually looking at how patients vary in their response to steroid inhalers. And the interesting thing from what, no, it wasn't Imran, it was Rupert that mentioned, is they even looked at the eosinophils in the sputum. So they've looked at the variation in patients. And so actually, there is an issue there about personalizing. The other aspect here is the COPD phenotype of pink puffers and blue bloaters. I think every GP here realize that every patient's different. And you do personalize your management according to the patient. But what seems to have increased the stratification of care and medicine has been the guidelines. And they've grown exponentially over the years, only go up to 2008 here. But they've had an impact. And as an example, if you think back to your COPD guidelines, they do stratify people into severity, and then you stratify the management according to the severity. But the QOF we did and is on its way out. If you look at the rationale for some of the QOF indicators, like this is from the QOF document, is stratifying people according to symptomatology, according to age, according to their risk scores. So we've been stratifying for ages, and we could embed genomics in here. But now turning to genetics. As primary care clinicians, we have been exposed to genetics for many decades. If you look, we started off with screening tests for PKU, neonatal screening tests, up to antenatal screening. We've been exposed to family history. And if you think of stratified medicine, familial cancer guidelines are stratified medicine. And nowadays, we're thinking about how this merges with DNA. And if you look at thalassemia and sickle cell screening, although it's not stratified healthcare, it is stratified screening. So if you look at the way that we screen for these conditions in the population, in areas with low prevalence, we are to stratify according to the ethnic origin of the patients. And when we actually do the test, this is a very busy slide, but when you have to do the test, you have to consider the value of the test. And let's for a minute forget that this is just a standard full blood count. You could have a normal genetic test, you could have an inconclusive genetic test, which is a variant of unknown significance, or you could confirm that they're a carrier, or you could confirm they've got the condition. So this is what we've done in the past, but it is still a stratification that will be relevant in the future. Now, every GP here has done NHS health checks, and it's part of a political and a screening drive. But I don't know how many of you have seen this flowchart. Have you seen it? So in this case, we're supposed to consider various factors, consider a risk assessment, consider modalities of behavioral change we want to implement, stratifying, consider other risk factors and other conditions, and stratify management according to that. From doing this, we're going to find people at very high risk. And the likelihood is they've got genetic disorders, particularly the young people. Then we're going to find people at high and moderate risk, which at the moment we take into account by environmental phenotypic factors. But in the future, we might consider genomics in there. And then people at low risk that need to be reassured. But if I go to the very high risk category, how many of the GPs have seen the NICE guidelines? So this is the very high risk group that have high cholesterols, strong family histories. And those that remember, we're supposed to assess these according to the NICE guidelines. That is cholesterol over 7.5, which we can do from computer searches, and family history of cholesterol or MI, which we need to look at using proper family history questionnaires. The problem with this is that what we do is we create a dichotomized population, one that is unlikely to have FH, one that might have FH or definitely have FH. And from that group, we're supposed to refer to hospital, and a small proportion of those will have FH. That's not a very good use of resources. So how do we improve that? And one thing we've proposed is you need to create risk strata. And in each risk strata, you do something different. So the very high risk strata, they have blatantly obvious FH. They could have cholesterols over 9.3. They could have a combination on an algorithm we produce that makes them at very high risk. So they go to specialists straight away. But then you've got this high risk group that we're not 100% certain what to do with them. So you want to explore other things. The most common thing we need to do is, can we take a proper family history? And then there's a larger group at population risk. But even in the very high risk groups, if we look at when we do an algorithm, there's some interesting things that come out here. In that very high risk group, if you look at the yellow highlighting, it's people at a very young age. That actually, if you're going to stratify your care, you want to get them into the service pretty quickly. What about interventions related to this? So those people identified with FH, you give them high intensity statins, but now the technology appraisals say we should give them PCSK9s. But there's a group that don't have FH that have very high cholesterol. And if you look at the technology appraisal, it says these group of people who have non-FH raised cholesterols, you do nothing. You don't give them PCSK9s. But there might be information that comes out of genomics that identifies in this cohort of patients that there is a certain subgroup that would benefit from PCSK9 inhibitors. But the other aspect is, traditionally when you cascade for FH, you identify the mutation and you cascade through there. Or if you can't identify it, use the phenotype, the LDL. But life's got more interesting recently with next generation sequencing. And this is a paper from Professor Steve Humphrey's group. That if you actually identify the mutation, yes, you do cascade screening. But if you don't identify the mutation, now that we've got next generation sequencing, we're picking up other things like these SNP scores, which identifies another group of people who have a high probability of polygenic FH, but you don't cascade, but they might be the group that could also benefit from the new agents. But then there's a low probability, and they're saying you actually cascade through LDL, which is probably going to go out anyway. Now I want to switch tracks completely. Another area that we're exposed to familial risk is familial cancer risk. And at the moment, most of the time it's demand pull, where the patients come in and say, I've got a relative, and in this case it was James Bond, Pierce Brosnan's daughter and wife who died from it. And for those who've been looking at this previously, is several of us in this room have worked trying to stratify the risk of having familial cancer into different strata. And in this case, it's colorectal, which is based on type and site of cancers and age, as well as strength of their family history. And based on those strata, people are either referred into the service or they're actually kept in primary care. NICE guidelines have actually brought this into the forefront of general practice. The problem we've had, though, is the guidelines have been too complicated. And GPs, if you think genomics is causing complications, when this came out, this caused lots of complications as well. So it's just that, like genomics, if you cannot stratify in a way that's easy for GPs, it doesn't get implemented. What that whole algorithm is supposed to show is that you stratify people into 3 strata. And interestingly, related to the previous talk, the strata is related to prognosis, not in terms of identifying specific conditions. So near population is low lifetime risk, moderate, and high risk. But as I said, this doesn't get implemented in primary care unless you have adequate decision support. And what we've tried is a tool called Pharos, which enables us to complete a questionnaire and then identify with the patients if they're at high risk, moderate risk, and even nuances between moderate and high and moderate and normal risk. It also provides us with lifetime risk and also risk of a mutation, which when I return to the NICE guidelines, you'll see is quite important. But what we've achieved from that, I'm not going to go into this slide in great detail, is 79% of the patients can be managed in primary care. And going back to the previous talk, the advantage of this is that as a GP using the guidelines, you could say that to the patient. But because we're using a tool that's used in secondary care as well, the actual engagement of the patient is much greater. Because we've actually said, look, this is exactly the same process you're going to do in secondary care. This shows that you don't need to be referred. And there's a group that definitely needs referring by NICE guidelines. But there's another group that NICE weren't clear what to do with them, so you're told to discuss with secondary care. But we could use technology to make that much more tighter. So returning to the guidelines, so you'll see there, as the strata not only are based on the family history, it's the lifetime breast cancer risk and also the mutation rate. So what do you do with that? If patients are at high risk, there's strong evidence you should give them chemoprevention. If they're at moderate risk, there's less evidence, and it's in NICE speak. When it's next evidence, is weak evidence, they say consider. If it's definite evidence, they say offer. So moderate risk is consider. And then the other thing is to stratify surveillance. And I don't know if any of you have seen this graph and this table in the NICE guidelines. It's very confusing. And I can't see how you could do it without decision support. But anyway, so this classifies people by age and by the nature of the high risk into how you actually provide surveillance for them. You'll see for moderate risk, most of it's do not offer. But what I would suggest is, with genomics, we might actually be stratifying this group of people into different strata as well. Now, the 100 Genome Project, I'm involved in that as well in terms of disparity subgroup and ethics on it. The reality is, it's not going to hit primary care soon. Sorry, it's not going to hit primary care soon. It's not, but stratified recruitment might hit primary care. So this is for cardiologists, but I think it applies to GPs as well, actually. It's about actually what sort of people want to be recruited for rare cardiac diseases. And so thinking of this, this could translate eventually into stratified care. But I want to end with a caution. Stratified care creates smaller groups, which is fine. But the one thing you have to be careful of is when you create the smaller groups, you don't create groups that you need greater sensitivity for. So in this case, Genome England want to recruit people that practice consanguineous marriages, which is fine. But the sensitivity with which that is recruited and how these people manage is very important. So when we split people into small groups, whether it be disability, ethnicity, or combinations, we need to think about the sensitivities of that stratification. And 25 years ago, when I got into genetics, I started off looking at consanguinity. And the biggest issue wasn't what we were doing, it was about the sensitivity of how we were communicating. But I don't want to leave on a sour note. So I'll leave on a quote that's many years old, but is still relevant, from Marshall Marinker. Anyone qualified from Leicester here? I don't know if did he teach you? No. But he back in 96, yeah.
Too old.
Okay, I wasn't asking your age. So we are moving from population probability-based prognosis to a personal predictive medicine. So he said this years ago, but we are still trying to get there. Thanks a lot.